History of both eye optic nerve head edema 3 months back with blast cells detected on bone marrow and CSF analysis, and was on reinduction with venetoclax, carfilzomib, intrathecal chemotherapy, and followed by cranial radiotherapy. On examination, the right eye had a best corrected visual acuity of 6/9 parts and an intraocular pressure of 36 millimeter of mercury. And he also had a 2 millimeter of pseudohypopyon and multiple undulations on the iris. Left eye also had 1+ cells in the AC. Fundus examination showed right eye grade 1 vitreous haze with a parafoveal scar, and UBM ultrasound biomicroscopy showed hyperechogenicity of the iris and thickening with variable depth of the anterior chamber. Left eye fundus was within normal limits. So considering a DD of intraocular metastasis, we went ahead with an AC tap where the histopathology showed lymphoid cells with scanty cytoplasm and cleaved nuclei, and immunohistochemistry was positive for CD3, CD10, leukocyte common antigen, and terminal deoxynucleotide transferase. The child was started on topical steroids, cycloplegics, and anti-glaucoma medication, and the oncologist started cladribine, cytarabine, idarubicin, and venetoclax. Within a month, the pseudohypopyon resolved with normal IOP, but both eyes showed persistent AC cells. The next month, again, the right eye vision dropped to hand movement with a 6 millimeter pseudohypopyon covering the pupillary area and high IOP. The oncologist started local radiotherapy, and we continued our topical medications. Again, post-radiotherapy, the pseudohypopyon resolved. 2 months later, the child underwent stem cell transplantation from his brother. But again, 2 months following the stem cell transplantation, the child developed blurring of vision in right eye, and we could see amorphous whitish deposits in the vitreous of the right eye. Bone marrow transplantation was planned, and 4 days following the bone marrow transplantation, the child reviewed with us, and then he did not have either AC cells or vitreous exudates in either eye. But again, another month following the bone marrow transplantation, the child presented with left eye pseudohypopyon without any vitreous involvement, which was managed with topical steroids and continuing chemo. Again, another 2 weeks later, the child had blurring of vision in right eye with the recurrent vitreous exudates. Went ahead with a right eye vitreous biopsy and core-vitrectomy, which was again positive for blast cells. So in conjunction with the oncologist, the child was started on weekly intravitreal methotrexate injections, and post 4th injection, the child was symptomatically better, but the 5th one had to be postponed as the child's platelet count has fallen to below 20,000. But again, 2 weeks later, the child presented with left eye redness, pain, and blurred vision. The best correct visual acuity was 6/36 with an intraocular pressure of 40 millimeter of mercury. And the eye had corneal epithelial edema with 4+ cells in the AC, and mixed hyphema and pseudohypopyon, again with undulations on the iris. B scan showed minimal dot echoes, and bone marrow as well as peripheral smear again showed blast cells. So if you see the timeline, initially in September 2024, there was documented optic nerve head edema with blast cells from the bone marrow and CSF when reinduction of chemo was done. And Jan 2025, 3 months later, the right eye had pseudohypopyon and the chemo was stepped up. Next month, again rebound hypo in the right eye, and radiotherapy was added. And after that, stem cell transplantation, and following that, again in June 2025, there were right eye vitreous exudates. Bone marrow transplantation was done. Next month, the other eye developed pseudohypopyon. Chemo was continued. And again, August 25, there was recurrence of right eye vitreous exudates, which was positive for blast cells, and weekly intravitreal methotrexate was given. And again, in the next month, the other eye developed pseudohypopyon and hyphema, and the child was advised reinduction with chemo. The oncologist advised to restart chemotherapy, but the child's parents wanted to explore alternative medicine. So coming to the discussion, ALL is the most common leukemia in children, where there is proliferation of lymphoid blast cells which overtake the bone marrow and lead to decreased mature WBCs, RBCs, and platelets. Ocular involvement can be in the form of direct infiltration of the eye in orbit by neoplastic cells, vascular abnormalities affecting the retina, or neuroophthalmic impairment. Leukemic infiltration of the anterior segment is rare and usually portends relapses. The internal limiting membrane usually acts as a barrier to leukemic infiltration, but cells can enter the vitreous from optic disc. Most are B cell origin with CD19 and 22 positivity. T cell lineage, as in our case, is with CD3 positivity. Topical steroids, anti-glaucoma medications, and local irradiation, plus systemic chemotherapy for the underlying disease can help resolve iris infiltration, pseudohypopyon, and secondary glaucoma. So the take-home message is ocular relapse in ALL implies a poor prognosis and needs urgent treatment. It may masquerade as an inflammation or infection, and a high index of suspicion is needed for timely diagnosis and management. Thank you.
Very interesting case.
Thank you.
A very good presentation. I want to ask you one question.
Yes.
What would you have done differently in this case to have a better outcome for the child? Because the child was already on chemo, and then you had done a CSF as well, and then child was under your management. So
Yes.
what could we have done better, if at all?
He was already on chemo and underwent bone marrow transplantation. So all modalities of treatments had been given to the child, and
Okay.
guarded prognosis was also explained.
Okay. Thank you.
Thank you.
The next presenter, Dr. Rolika Bansal, are you here? Dr. Rolika Bansal is going to talk about comparative analysis of tumor control by indigenous versus imported ruthenium 106 plaque brachy.
It's not showing their system. All right. Okay.
The next presenter, Professor Dr. Deepak Mishra. Are you here, sir? Dr. Bhaskar Kudatini, are you here? Dr. Bhaskar Kudatini is going to talk about interplay between primary chronic dacrocystitis and meibomian gland health.
Good morning, everyone. Today my name is Dr. Bhaskar from Mysore Medical College. Today I am going to present interplay between primary chronic dacrocystitis and meibomian gland health. Ethical clearance was obtained from the Ethical Clearance Committee, and financial disclosure is nil. The primary chronic dacrocystitis is defined as inflammation of the lacrimal sac, typically caused by the obstruction of the nasolacrimal duct, and meibomian gland dysfunction is a common comorbidity of the primary chronic dacrocystitis. This is how the meibomian gland dysfunction is occurring in PCD. Is mucopurulent discharge is causing chronic inflammation and bacterial colonization that is leading to altered tear film composition and meibomian gland dysfunction. These are some photographs showing chronic dacrocystitis. Need for the study is understanding the relationship between the primary chronic dacrocystitis and the meibomian gland dysfunction and the impact of the DCR on DCR. The aim is to evaluate association between MGD and PCD and effect of DCR on tear film stability and MGD. Materials and method, it is a prospective interval study done for the period of 1 year. We have included adult patients diagnosed with unilateral acquired PCD. We have taken 50 cases and 50 controls. Controls are other normal eyes of the same patient. PCD was diagnosed based on the epiphora, mucoid and mucopurulent discharge with the nasolacrimal duct obstruction confirmed on syringing. We have taken detailed history and comprehensive examination done. We have assessed based on 12-item ocular surface disease index questionnaire, MG expressibility, T-BUT, tear meniscus height, Schirmer's test, and we have done DCR and followed up for 8 weeks. Results, we have taken almost 74% of the female patients were included in our study, and 50 cases and 50 controls. Age range between 21 to 75 years. MG result, MG expressibility, initially it was high, post-operatively it is decreased almost grade 2, more than or equal to grade 2 was in found in more than 90% of the patients. Schirmer's and tear meniscus height initially high, it is decreased to almost near normal. The preoperative high values may be because of lipid deficiency and decreased drainage and reflex secretion. T-BUT is high initially, maybe because of gland destruction. It is post-operatively increased. OSDA score is also decreased post-operatively, but it does not come to normal, maybe because of permanent meibomian gland destructions. This is the photograph showing preoperative and postoperative TR meniscus height significantly reduced TMH postoperatively. Discussion. MGD is a vicious cycle in PCD. Chronic inflammation is causing mebum stagnation and hyperkeratinization, and melting point of the mebum is increased. It is leading to gland obstruction and atrophy, leading to MG damage and MGD. As I mentioned, MGD prevalence is increases with age. 72% in those aged more than 60 years. In our study, 7 out of 50 subjects aged more than or equal to 60 years. MGD is more common in men, but the study had more females due to PCD being more common in females. R. Goel et al. Concluded the strong association between PCD and MGD. J. Hong et al. Demonstrated significant changes in meibomian glands in patients with unilateral PCD. As I mentioned earlier, Schirmer's and TMH may increase compensation for lipid deficiency in early MGD status. Post-operatively, tear secretion is decreased as the tear outflow was restored. T-but reduction in PCD is likely due to goblet cell destruction from chronic inflammation. Post-DCR, T-but increased to the level with controls. OSTI score improved after surgery, indicating symptoms relief, but remained higher than the controls. Limitation of this study is we don't have mebography in our institute. We did not do this, and lack of tear inflammatory cytokines. Pre-existing MGD before PCD is not ruled out. Short follow-up period. Conclusion. PCD can cause significant functional and morphological disturbance in meibomian glands, leading to MGD. Strong association between PCD and MGD likely due to chronic inflammation induced gland obstruction. DCR surgery can restore functional meibomian gland changes and tear film stability, but does not reverse the structural meibomian gland loss. Thank you.
How do your findings correlate with existing literature on the same kind of study?
It's almost near normal, ma'am, with reference articles.
Most of them?
Most of them.
Any major study which you know?
R Goel et al.
You mentioned it?
Yes, ma'am, I mentioned.
Okay, okay. All right, thank you.
So in a patient of PCD, regarding the PCD patient will come to you many a times with just complaints of watering. What would you counsel the patient?
Discharge, ma'am.
The patient comes to you with watering complaints. What would you counsel the patient regarding, in reference to your study?
Mucopurulent discharge, ma'am.
It's okay. Good presentation.
Thanks.
Our next speaker is Dr. Rolika Bansal. She will be presenting comparative analysis of tumor control by indigenous versus imported ruthenium-106 plaque brachytherapy.
A very good morning to all. Could you please display the presentation? A very good morning to all. So I'll be talking today on comparative analysis of tumor control by indigenous versus imported ruthenium plaque brachytherapy. We have no financial interests. So as the evolution of plaque has seen over a century, we have gone all the way from Dushman, where in 1915 he started assessing the different materials that can be used or radioactive isotopes that can be used for plaque brachytherapy, the different placement techniques. We have gone from radon all the way to iodine. We have gone to the COM study, which proved that plaque brachytherapy is equal to enucleation, therefore it should be preferred. And we have gone all the way to episcleral plaque brachytherapy. This is how we have evolved. And we have seen that ruthenium plaque brachytherapy, which is a beta emitter, has been used because it's a longer half-life than the others. It has reduced dose delivery to the normal adjacent structures, and it has lesser radiation-induced side effects. This is the reason why we prefer ruthenium for surface tumors, as even conjunctival melanoma, even iris melanoma. and in cases with intraocular cases like choroidal melanoma, choroidal hemangioma, and even for retinoblastoma. So this is the spectrum for which ruthenium plaque brachytherapy has been used over the years. And this is the plaque that we have been using all the way, which had high cost and import duties. So this is the imported plaque that we were using for all these years. And because of the import duties, we had limited centers for plaque, restricted availability, and affordability issues. So to combat that, we went into the Make in India, Recreate, wherein India goes indigenous. And we came up with the plaque brachytherapy, which is absolutely indigenous, and that was developed by BARC, which is a low-cost plaque. And this has been made from Kalpakkam radioisotope waste, and it has been purified, and it has been put together and electroplated on the plaque. And that's how we have come up to the study wherein we are comparing that the plaque that we have been using all the way, is it similar or is it better, or how is it to the new plaque? Because before doing something, we need to have a correct proof for it. So therefore, we assess the local tumor control in all the surface lesions and intraocular tumors between the two plaques. And we did a retrospective analysis where we had nearly 315 cases in the imported plaque and 101 cases indigenous. This is the spectrum of how we exactly do the plaque brachytherapy, where there's a diagnosis made, documentation is done, assessment is done, dosimetry planning is done, and therefore plaque is inserted, regular follow-up and documentation comparison is performed. This is the video all the way from 2020. That's when we started the plaque brachytherapy. And as you can see, that because of the indigenous plaque, we have been able to bring this all the way to India in our own state-of-art ORs. And we have been able to successfully perform these procedures. So if you can see over here, the analysis showed that we have nearly similar outcomes in both the plaques. In ocular surface lesions also, we have gone to a good vision salvage rate, to a high eye salvage rate, and 100% life salvage rate. And we are changing the face of it, and we have a good follow-up now. So this is the analysis which has been done earlier. But have any of the studies commented on the cost? No. So we have been able to comment on the cost, and we have been able to state how it's different. So if to summarize this and make it easier to understand, if we talk about ocular surface lesions, with the imported plaque, we have been seen that life salvage is 100%, eye salvage is 100%, and vision salvage is 78%. As you can see, excellent outcomes there. If we talk about the indigenous plaque, that is the BARC plaque over here, the vision salvage is 80%. We have seen excellent outcomes with even this plaque. Now, when we talk about the intraocular tumors, the salvage rates are also very high. 100% life salvage rate, 81% for the eye, and 60% of the vision with the imported plaque, and see excellent outcomes over here. Again, there's a slight increase in the indigenous plaque, could be because of a different follow-up. That is 96% in BARC plaque with excellent outcomes, as can be seen over here. So if we say, we can conclude that indigenous plaque is non-inferior or statistically non-inferior and therefore similar to the imported plaque, but there's a cost reduction by 95%, which is a very significant cost difference. So we suggest the usage of this indigenous plaque for the intraocular tumors and the surface tumors, as it is non-inferior to the imported one, with excellent long-term vision, eye and life salvage, with significant cost reduction. 95% is no joke. An increase in availability to the society, and we have been able to support the Made in India initiative. Thank you very much.
I congratulate you on conducting such a beautiful study and designing it this way. Ma'am, any questions?
Wonderful presentation and a very good lesson for us to go indigenous.
Very nice.
So Dr. Deepak Mishra, are you here? No. Move on to the next presenter, Dr. Mahima Kaushal. Dr. Mahima Kaushal is going to talk about triple drug super selective intraarterial chemotherapy for retinoblastoma in Asian Indian population.
Childhood, cancer, chemotherapy. A trio no parent ever wants to hear and no doctor is glad to face. And what's more, the standard IV chemotherapy doesn't just attack the tumor. it travels the whole body, leaving behind a trail of toxic side effects. This is where super-selective intra-arterial chemotherapy has changed the game. So with this background, let's explore triple drug super-selective intra-arterial chemotherapy for retinoblastoma in the Asian Indian population. The journey of intra-arterial chemotherapy spans decades. Here's a quick timeline. In 1958, Rees was the first to use it with triethylmelamine through the internal carotid artery. It was abandoned due to systemic toxicity. Then in 1968, Kiribuchi reported tumor regression via ophthalmic artery infusion. This was followed by melphalan introduction into the intra-arterial chemotherapy regimen with a balloon catheter in the 1980s. Then in 2006, Gobin and Abramson refined the technique of ophthalmic artery catheterization and standardized the term super-selective IAC as we know it today. Here are the various types of IAC terminologies depending on their methods of administration and indications. The procedure starts by marking the correct eye with large arrows and ipsilateral thigh whose femoral artery is to be accessed. A 5 French catheter is advanced through the femoral artery, then the aorta to reach the ophthalmic artery ostium as seen. Brain angiogram and a choroidal flush is seen to confirm the location. This is followed by administration of the chemotherapeutic drugs diluted in 30 ml of saline and manually infused over 30 minutes in a pulsatile fashion. The therapeutic drugs themselves have evolved over time from a single agent melphalan to triple agent melphalan topotecan carboplatin added by Abramson as we know it today. So we conducted a retrospective consecutive interventional case series analyzing 157 cases in which 163 eyes underwent a total of 414 IAC infusions. At a mean follow-up of 5 years with a range of 1.5 to 7 years, we are proud to report 100% life salvage. From the following figures, we can deduce that unilateral eyes are more often treated with primary IAC, while bilateral cases usually had IAC as a secondary measure. On ICRB group-wise analysis, IAC was mainly chosen as the first line for group D and E cases, while secondary was used in historically D and E grouped cases and in almost 1/3 of the cases grouped and treated elsewhere before presenting to our center. The main indications that arose for secondary IAC in our study was for tumor recurrence in 50% and refractory or residual tumor in the other half. In both the primary and secondary groups, significant eye and vision salvage numbers were achieved. Among the eyes that needed enucleation, most of them were due to tumors not responding to treatment, while the remaining 10 eyes, which were 20%, were enucleated due to recurrence. So a 5-year enucleation-free period could be achieved in overall of 72.6% cases as seen from this Kaplan-Meier graph. Here's a glimpse of outcomes of how our patients fared with IAC. A case of 8-month-old child with group B retinoblastoma showing complete regression in the form of calcification after IAC completion. Group D retinoblastoma on its way to a beautiful regression in a 3-year-old child. Group E clearing up after primary IAC, making the disc visible. And here's how some of the secondarily treated eyes fared. The strength of our study is that we were able to achieve excellent regression in lesser number of cycles of IAC with better globe salvage at a longer duration of follow-up. This was seen even in advanced cases, especially group D and E, representing a very real-world cohort and not cherry-picked cases. Our study builds on the foundation laid by a prior review where the authors highlighted the importance of careful patient selection and the need for a multidisciplinary team. But we must remember the cost plays a large role, as IAC costs 10 times more than IVC. Triple drug superselective ophthalmic artery for retinoblastoma has shown excellent efficacy. There's targeted delivery with minimal side effects, but high cost makes IV chemotherapy still more accessible in many of the developing countries. Thank you.
A very good presentation, but as you said, the availability of IAC and the cost limit its use. So going forward, as you are a very young ophthalmologist, going forward, how would you like to incorporate this to reach the maximum number of audience or the deserving child?
It can be reserved for cases where the tumor is not responding to conventional IV chemotherapy.
So you would like to go for conventional chemo first, and then if it's not responding, then go for IAC?
Yes, because secondary has also given very beautiful results, and live salvage and globe salvage is commendable over there.
Okay, thank you.
What about the systemic microstatices which could take place?
If there is pre-existing systemic micrometastasis which can be radiologically evident, then we cannot go for IAC because it will only give local tumor control. It does not protect from systemic metastasis.
So
In that regard, IV chemo is better.
All right, thank you. Our next speaker will be Dr. Shiva Nanga Shravani. She will be speaking on retinoblastoma in the first year of life, clinical manifestations and treatment outcomes.
Very good morning to one and all. I am Dr. Shravani Ararapu, and I would be speaking on retinoblastoma in infants, that is less than 1 year of age, the clinical manifestations and treatment outcomes. There are no financial disclosures, and this is the outline of my presentation. Introduction. As we all know, retinoblastoma is the most common intraocular malignancy in children. In this study, I would like to emphasize upon infantile retinoblastoma. This is the review of literature. There are few international papers that have been published regarding the infants retinoblastoma, but there are not as much Indian studies so far. Lacunae in literature. As I said, there's paucity in literature regarding infant-only based RB studies, and there is limited Indian population data. So the rationale of the study is that infant retinoblastoma have unique challenges, that is due to the younger age of presentation, the bilateral disease, high germline risk, and the treatment modality, the treatment morbidity that is involved. So this study aims to address this major gap in the literature. Aim and objective of my study is to evaluate the clinical spectrum, treatment outcomes, and prognostic factors of the retinoblastoma in infants. The place of study is at RP Center, AIIMS, New Delhi, and it's a 5-year retrospective single-center observational cohort study done between 2018 to 2022. We have taken the ethical clearance. The inclusion criteria includes infants less than 12 months of age and who have been clinically or histopathologically confirmed retinoblastoma. The results are as follows. We have found that there is a slight male predominance and majority of the patients present between 3 to 9 months of age. And there is bilateral disease in almost half of the infants. And leukocoria was the dominant presenting feature in most of them. Based on the IRSS staging and ICRB grouping system, it was found that most of the infants, that is nearly 92%, have intraocular retinoblastoma, and they presented with an advanced disease, that is with group D and group E. Systemic chemotherapy have been used in nearly 68% of infants and most commonly in the bilateral retinoblastoma cases. And enucleation was done in 44% of retinoblastoma eyes, and focal treatment like transpupillary thermotherapy, cryotherapy, and other treatments like EBRT, that is external beam radiotherapy, and IAC have been used in selective cases. This is the outcomes. The overall survival rate was 93%, and the globe salvage rate was nearly 56% in our study. The follow-up duration was nearly 2 years, and we have done a subgroup analysis as well between less than 6 months and greater than 6 months infants, which have shown that chemotherapy was most frequently used in greater than 6 months of patients, and mortality rate was higher in less than 6 months infants. This is a comparative review of literature, and in our study it shows that, and comparing with the remaining studies, it shows that majority of the studies, it is nearly 9 months at the age of presentation, and bilaterality and family history are more in neonatal cases, that is less than 28 days of presentation. Leukocoria was the major presenting complaint, and the first line of the standard in the modern cohort is the systemic chemotherapy plus focal treatment. And radiotherapy was mostly avoided in infants due to its high complication rate. And enucleation was done historically high rate in previous studies, but it has decreased over the recent studies due to the chemotherapy and IAC advances. And the overall survival was greater than 90% across the studies. The limitations include retrospective and a single center study and a short follow-up duration. I would like to conclude that leukocoria remains the predominant presentation in our study, and our study has shown that the family history is significant in neonatal cases with an overall survival of 95% and a globe salvage rate of 56%. I would like to recommend saying that systemic chemotherapy with focal consolidation would be a good recommendation for treatment of infants with RB, and it is better to avoid radiotherapy due to its long-term complications. Early referral, genetic counseling, and identification of high-risk groups are essential. These are my references. Thank you so much for the patient hearing.
So what is your takeaway message? Could you just repeat it again?
Ma'am, I would like to emphasize that treatment of patients in less than 1 year of age and is different from that comparing to the other pediatric cohorts. In less than 1 year of age, there is much response to chemotherapy, and there is difficulty in doing IAC, and there is major morbidity while doing radiotherapy. So I would emphasize on using systemic chemotherapy as the first line, and selective focal treatment like TTT or cryotherapy that can be used. In our study, that had given better results. And genetic counseling, because of the bilaterality and the family history, is essential.
How many infants presented to you as a case of positive family history and the parents just brought the child just because the sibling had a retinoblastoma? Did you have any such cases?
Yes, ma'am. We had a total of 205 infants. Out of that, there were 11 patients with family history.
They did not had the manifestations of RBS yet, but because the sibling had, it was caught early.
Just with the sibling screenings, maybe we could pick up like 3 to 4. We generally do examination under anesthesia for the sibling screenings as well. So we could pick up like 3 to 4 cases, but everyone are not that willing. So we were trying to counsel it more to bring the other siblings as well.
Thank you. Good presentation. We call upon the next speaker, Dr. Rohan Raj. Are you here? Dr. Rohan Raj. Moving on to the next one, Dr. Anu Sharma. Dr. Anu Sharma would be speaking about retinal sensitivity evaluation after chemotherapy and radiotherapy in retinoblastoma treatment.
Good morning, everyone. The topic of the presentation is the retinal sensitivity evaluation after chemotherapy and radiotherapy in retinoblastoma treatment. There are no financial disclosures and no conflict of interests. As we know, retinoblastoma is the most common neoplasm of the pediatric cancer, comprising of around 3%, wherein 80% are treatable. In high-income countries, more than 95% has a cure rate. The treatment includes conventional chemotherapy and various targeted therapies with the modern treatments. But the concern is the ocular toxicity, which impacts the retinal structure and the function. So there is always a need to evaluate the functional outcomes, not just tumor control. Apart from the life salvage and the globe salvage, the quality of vision is the most important thing which has to be addressed in survivors. So we conducted a study on retinal sensitivity, which is a functional indicator of the visual potential. The aim of the study, the primary objective and the aim is to evaluate the effect of the chemotherapy and the radiotherapy in retinoblastoma patients in terms of retinal sensitivity. And the secondary objective is the other variables which we obtained with the microperimeter to assess the fixation parameters in the extramacular regressed retinoblastoma. The evaluation tools used for the microperimeter which we used was the scanning ophthalmoscope microperimeter, MAIA, and we also used Optos retinal ultra-wide field camera, which complemented the microperimeter to identify the peripheral tumors. So these are the maps we obtained, the retinal imaging we did. The study was conducted at Dr. RP Center between January 25 to June 25. It was a prospective comparative and observational study. So we included 14 patients with more than 14 years of age with visual acuity better than 618 so they could perform the test. And we also included 20 age-matched healthy controls. The macular sensitivity was measured using center view MAIA with a 37 stimulus grid. It covered 10 degrees of field. So we mainly used retinoblastoma survivors with history of more than 1 year of any treatment. And we excluded the macular lesion because it is difficult to perform the investigation. And we also excluded the active tumors. So 60% of the participants in the control group were males and 40% were female. As we already have come to know that there is a slight male preponderance. So 72% in the subjects were male and 28% were female. Mean age was 16 years, and in the RB survivors, mean age was 17 years, so statistically significant. The vision was better than 6/18. In the control group, the mainly vision was 6/6. So the key parameters of the microperimetry were retinal sensitivity, macular integrity index, and fixation parameters were P1 and P2. So I'll explain one by one. Retinal sensitivity is the average threshold across the tested points. The normal is 26 to 30 decibels, which is reduced in various inherited retinal dystrophies, ARMD, CSR, and glaucoma. So as in our study, we also saw that retinal sensitivity was reduced in the subjects. It was 26.6 compared to the normal control, which is around 30. Macular integrity index is another parameter which is a proprietary value of the equipment. It's a global index and expresses probability score from 0 to 100. So depending on the severity of the disease, the number shows the higher values indicate the higher disease severity compared to the lower values where the disease is less. So here, as we see in the disease group, the MIA index is 77, which is higher in the subjects compared to 54.4 in the controls. Fixation variables are the measure of fixation stability, which shows that how the patients are fixing with the macula. It is expressed in the P1 and P2 values, which are the percentage. In controls, it was P1 value was 95% compared to 71% in subjects. So P1 is actually the percentage of fixation points within 2 degrees of the diameter circle, which is positioned at macula. So as we see, even the fixation is affected in the diseased group, which is 71. P1 is 71 in the disease group and P2 is 86 compared to around more than 90% in controls. So as we've seen, even if the disease is extramacular, it does affect the macular fixation. And this is clinical significant also. So these are the maps of the macular as well as extramacular retinoblastoma groups. The perimetry was done by in both the eyes, and as shown in the maps, the one with the macular retinoblastoma has a central scar, so the macular sensitivity is almost 0 to 10. And where is in the extramacular, although the retinal sensitivity is preserved, but it is less than normal value. So fixation location and fixation type is another parameter which is shown by the microperimetry. There is no such study conducted, but there is one case report published by Johnson KP where they did perform microperimetry in a macular retinoblastoma to show the preferred retinal locus. So to summarize, we want to tell that microperimeter can be used as an additional tool for the functional assessment because it picks subtle functional deficits in structurally normal appearing areas which we see on clinical pictures and OCTs. Reduction in retinal sensitivity is a noteworthy side effect, and assessment is essential in diseases treatment monitoring. Thank you.
A very informative presentation. Thank you.
What was the power of the study which you calculated for this?
The power was more than 90%.
Okay, all right. Upon the speaker, Professor Dr. Deepak Mishra. Is he here? Another presenting author, Dr. Rohan Raj, to speak on unusual presentation of lacrimal sump syndrome. Is he here?
Are the speakers for the final presentation here? Dr. Shivian Srivastava, Dr. Vidushi Dikshit. Dr. Vidushi. Okay. So, Dr. Shivian, he'll be presenting on the ICG enhanced transpupillary thermotherapy for treatment of circumscribed choroidal hemangioma. Choroidal melanoma with seeds supported by pathology and scanning electron.
The science of today is the technology of tomorrow. Good morning to one and all present here. I'm Dr. Vidushi, and I'm here to present my case, malignant choroidal melanoma with seeds supported by pathology and scanning electron microscopic study. We hold no financial disclosures. Uveal melanoma, as we all know, is the most commonly occurring primary intraocular tumor in adults, and choroidal melanomas comprise about 80% of these diagnosed uveal melanoma cases. In today's case, we report a patient who was later diagnosed to have a choroidal melanoma, presented with vitreous seedings despite being a treatment naive patient. This clinical diagnosis was supplemented by histopathology, immunohistochemistry, and field emission scanning electron study, which is the novelty of the study. This was done in conjunction with IIT Guwahati. The purpose of this study was to present an exceptionally rare case of malignant choroidal melanoma with vitreous seeding and supporting it with histopathology, immunohistochemistry, and FESEM. Coming to the case proper, we had a 58-year-old gentleman presenting to us with painless diminution of vision in his left eye for past 1 month. Patient had no known comorbidities. A comprehensive ophthalmological examination was run for this patient, wherein right eye was reported to have a normal anterior and posterior segment with a vision of 6/6 and an IOP of 10. And the left eye, however, presented with a retrolental mass, even though the AC was quiet. The vision of this eye was hand movement, recognizable only close to the face. On a meticulous indirect ophthalmoscopy, a raised melanotic mass was noted, and with subretinal fluid and exudative retinal detachment. We run a USG B scan for this patient, wherein a mass arising from the choroid from the inferior nasal aspect of the globe, extending into the vitreous cavity with hallowing and posterior acoustic shadowing was noted. As a part of the metastatic workup, as well as to know the extent of this tumor, we run a T2 weighted MRI, which furthermore confirmed the diagnosis. Unfortunately, this patient had to undergo enucleation, and on enucleation, we can see that there is a mass with an exudative RD. This mass was 18.92 in basal diameter and 14.37 in its height, with histopathology suggestive of spindle A, B, and epithelioid cells, confirming the diagnosis of a choroidal melanoma. The vitreous seeds were confirmed with HMB45 positivity, and these seeds were further examined under FESCM to find out the diagnosis and differentiated from macrophages loaded with pigments or other inflammatory cells that could have been a part of this vitreous in the setting of a choroidal melanoma. In conjunction with IIT Guwahati, we tried to analyze the structure of these vitreous seeds, and after this examination, we could see that these seeds revealed having a spherical structure with smaller spherules and irregularities of pigments on its surface. The take-home message is, despite that this patient was choroidal melanoma, was treatment naive, choroidal melanoma can rarely present with vitreous seeds even in such cases. It is always wise to have a suspicion and never leave these patients just thinking that just because they have not undergone a treatment or a biopsy further in earlier days, that they can be devoid of vitreous seeds. Also, this study highlights the importance of having a creative mind open and having advancements in our imaging modalities hereafter. Thank you. I would like to acknowledge my mentor, Dr. Harsha Bhattacharjee sir, and the Department of Ocular Pathology at SSDN. Thank you.
I would like to ask you one thing. How does the recent investigative modality that you've talked about help in further evaluation of patients or an early pickup of the disease? Would it help?
Ma'am, not in this case, because this was one of the earlier reported cases. We don't really have a lot of literature in the first place. But if at all we use these modalities, and like this patient presented much later with a mass which was really big. If we employ these modalities in a smaller masses, or sometimes these cases are really missed, if we can employ them earlier in the stages, for sure we will know that this patient is going for malignancy, and earlier and a more tailored plan can be structured for them.
Thank you. Good
Thank you,
presentation. Dr. Shivian, are you ready?
Good morning to everyone present here. My name is Dr. Shivan, and I'm going to be presenting on indocyanine green enhanced transpupillary thermotherapy for the management of circumscribed choroidal hemangioma. I have no financial disclosures and no conflict of interest. Choroidal hemangiomas are benign vascular hematomatous tumors. The circumscribed lesions are associated with non-syndromic cases usually. The diagnostic tools that we employ are ultrasound, fundus fluorescein angiography, indocyanine green angiography, and OCT. And the treatment methods are varied, out of which we chose to focus on transpupillary thermotherapy for the purpose of our study. So indocyanine green dye has similar light absorption spectrum as the wavelength of laser that is used in transpupillary thermotherapy. That was our rationale. Photodynamic therapy, although it is an effective modality, is very expensive, and the dye is very difficult to obtain a source in our country. A cheaper treatment with more easily available dye and good efficacy can help treat a wider spectrum of patients. The strict light precaution measures are not required after ICG-TTT as compared to PDT. So our hypothesis was that ICG-enhanced TTT may reduce the number of treatment settings required and decrease the power of laser compared to TTT alone. Coming to review of literature, it has been seen that indocyanine green dye has been associated with increased uptake of diode laser energy. It has been associated with better visual acuity outcomes as compared to PDT before, and in another study as compared to TTT. The primary objective was to evaluate the resorption of subretinal fluid, tumor response, and the total duration of treatment with ICG-TTT, to determine changes in visual acuity and side effects, and to compare it with TTT was our secondary objective. The study took place over a period of 2 years. It was an ambidextrous comparative interventional study. There were two groups, 15 patients treated with TTT and 15 patients treated with ICG-enhanced TTT. The inclusion criteria involved patients with CCH with height less than 4 millimeters, largest basal diameter less than 10, subretinal fluid height of less than 6, and a clear refractive medium. The treatment was performed using an indirect ophthalmoscope equipped infrared diode laser at 810 nanometers. The initial power was 300 milliwatt with a 50 milliwatt step up in case of in case the grayish-white discoloration was not obtained on the surface of the tumor in 30 seconds. The number of sessions on 1 to 4 repeated over after 1 month. This is the methodology. We did a baseline workup. Then the patients were treated with ICG-TTT, and further follow-ups were done after a month, and further treatment based on the tumor characteristics at that follow-up, over 4 follow-ups. We saw visual acuity and side effects and patient factors, the axial thickness and the largest basal diameter and the tumor characteristics, and the treatment factors were power required and the number of sessions or duration of treatment. Coming to results, there was no statistically significant difference between both the groups when it came to mean age, sex, presenting complaints, and duration of symptoms. There was a significant difference, improvement in logMAR visual acuity in ICG-TTT group as compared to TTT group with a p-value of 0.0476. There was also a significant decrease in axial thickness and largest basal diameter in both the groups, with no difference between the groups. As we can see in this clinical picture, we can see the choroidal hemangioma with scarring in the Optos clinical picture, and in the lower picture we can see the decrease in the axial thickness and the largest basal diameter using ultrasound. Here's another example. We saw that there was subretinal fluid resorption of 15 out of 15 cases in ICG-TTT and 14 out of 15 in TTT. There were a few cases in which we saw dramatic improvement, for example in this case where subretinal fluid and intraretinal fluid both resorbed. There was a significantly lesser power required in ICG-TTT group as compared to TTT group with a p-value of 0.002. But we saw that there was no significant difference between the number of sittings of laser required between both the groups. Hence, the duration of treatment between both the groups was similar and there was no difference noted. There were also no side effects noted as a result of treatment in our study. So to summarize, is ICG-TTT an effective treatment modality? It is. There is significant improvement in logMAR visual acuity with good tumor response indicated by decrease in tumor size and thickness and resorption of subretinal fluid in macular region. There were no significant side effects noted as a result of the treatment in our study. However, the low sample size is a negative factor against that. ICG-TTT resulted in better visual acuity improvement as compared to TTT and required significantly lesser power to achieve similar tumor response. And there was no significant difference in the duration of treatment required to achieve the same outcome. The limitations were that we had a small sample size and short duration of follow-up. Ideally, we'd like to follow up the patients for a longer period of time. And there were limited number of cases with regards to different locations of tumor to prognosticate visual and tumor regression outcomes in cases of submacular and non-submacular tumors. Thank you.
So, any other study in the literature which you could correlate it with?
There have been studies conducted previously. They have mostly compared PDT with TTT. There was one study in which they compared ICG-TTT, TTT with PDT, but it was a retrospective analysis in which they found that visual acuity outcomes were better with ICG-TTT in their study also. But there was no significant difference in the tumor response in both the studies.
All right. That's all.
Thank you.
Okay.
Thank you. We call upon the previous absentee presenters if they are here. Dr. Deepak Mishra or Dr. Rohan Raj, are you here? Okay. All presenters for their wonderful presentations. Thank you so much.
We can just have a photo session here with all the presenters. हमारे पास टाइम तो है, टाइम तो है हमारे पास. 2 presenters.